So it's my pleasure to have with us this afternoon in the series I'm calling Reflections from Pharmacy Leaders Advancing the Profession, Dr. Toby Herfindal, who is the founding chair of the department in the Department of Clinical Pharmacy at UCSF. And he's also was a pioneer in establishing various clinical pharmacy services at UCSF. He was involved with the infamous 9th Floor Project at UCSF. He was the editor of the first one of the first clinical pharmacy textbooks, Clinical Pharmacy and Therapeutics, along with Hirschman. And he authored a regular drug therapy column in a national pharmacy journal as one of the first to do that. He's also has worked with the biotech company and was a founder and CEO of a national oncology alliance company that actually managed services for medical oncology practices. He was the president of the California Society of Health System Pharmacists, member of the board of directors of ASHP, and was named by California Society of Health System Pharmacists as a Pharmacist of the Year. So it's my pleasure to welcome Dr. Herfindal.
Thank you very much.
So we'll start off. We'd like to learn more about your journey to your recognition as a leader. And when you reflect on your journey, you may wish to include key events and or key people that help shape or influence you in this journey.
Well, I did have a lot of help over the years, that's for sure. And I'm still struggling with the idea that I was a leader. I'm not sure if I set out to be a leader or you can actually train a leader, but that's a better question for you, I think. But my career spanned about 50 years of various aspects of pharmacy. Even the last 25 years when I went into more physician-oriented ideas and companies, but I had started out to be like my uncle. My uncle was a small-town pharmacist. He was probably the wealthiest man in town, so that influenced me. He owned a pharmacy in a 500-acre cattle ranch. He drove a big Buick, and I said, well, that's for me. And he gave me a job, actually, after school, starting, I think in my sophomore year, working in the pharmacy, opened it up every morning, and went down to the train station to pick up the San Francisco Chronicle, brought it back, made coffee for the local farmers, and in violation of the law, actually. I realized many years later that you can't open a pharmacy without having a registered pharmacist on site, but I would open it for an hour in the morning. And they would sit around and chat and drink coffee and read the paper. And I was busy cleaning the place up, doing the windows, putting stock away, and getting ready to go to school. And then after school, I was also working in the pharmacy. So that was my initial orientation. My initial thought about pharmacy was to own a pharmacy, and he was thinking that I would come back because his children were not interested, that I eventually would take over that pharmacy. And I think to his disappointment, I got ruined by my experiences at UCSF. But in the subsequent 50 years, I was involved in community practice, military pharmacy. I was a captain in the Air Force. And this was during the Vietnam thing, and it was right after I got out of school. Then I got recalled by the dean of the pharmacy school after I graduated, a couple of years after I graduated. And he said, we have this idea that we're playing around with, and a lot of people are thinking about it. That was Jerry Goyen. I don't know if you ever met Jerry, but he was my dean. He subsequently became commissioner of the Food and Drug Administration. So he was clearly an influential person in my life. And then later on, after the 9th Floor Project went along and became a thing, it was originally categorized and classed as a pilot project. And when he gave me the job, he said, I have 9 months worth of money and I can't guarantee you a dime after that. It all depends on whether this is going to work or not. So I left my little Central Valley town where I worked in a Rexall drugstore, and went to San Francisco and participated in the we call the ninth floor pilot project, along with people like, I think you talked to Bill Smith, and Joe Hirschman was another one, Rich DeLeon, Bob Miller, a number of others over the years that were very influential for me. As time went on, the little 5-person group kind of grew, and pretty soon we were too big to fit into the organizational structure that they had, and the dean decided he needed to have a department or a division of clinical pharmacy and split us away from the Department of Pharmaceutics. And he asked me to chair that department, and I did that for the next 20 years. At a very important time in our development, our personal development, and the growth of clinical pharmacy, as we started to call it, it became, we would have, in any particular year, we would have thousands of visitors come to hang around. Most of them were there to see how they could maybe copy it or adapt it to their environment. And then a subset was there to see how it couldn't work. You know, it's impractical. It's not something that's ever going to work. And it was probably partly luck, partly, I think most of us knew that if this didn't work, we didn't know what we were going to do. We were frustrated. We felt we were overeducated. The School of Pharmacy, when I graduated in 1965, was very focused on being scientifically sound. So we had the usual academic sorts of courses, a little bit therapeutics, but not very much, mostly pharmacology, but a lot of chemistry. We had chemistry up to here. And we were told that we were going to be drug therapy managers, and we went out and tried to get a job, and nobody had ever heard of a drug therapy manager. There was no such thing. So we were all sort of frustrated enough to say, well, maybe we can make this work. And we worked at it, and with a lot of support from the chief of staff, the physician who ran the place, the administrator of the hospital, Bob Durzon, who eventually went to Washington and became head of the Medicare, I guess. Very, very supportive, and not only rhetorically supportive, but they were supportive in terms of giving us money, giving us status, giving us space to function. And that continued to grow, and we grew and grew and grew, and pretty soon the curriculum changed. We had a curriculum meeting where the 5 of us, the big 5, the young Turks, sat in front of the faculty and said, our curriculum really sucks. It's not right. It's just not doing what we should be doing. We're getting our students up here, we're going on rounds, we're doing all this stuff. They don't know it. They don't know anything about, they know pharmacology, pigeonhole pharmacology. They could put the drugs into the right category. They didn't know how to use them. They didn't know how to use 2 different drugs or 3 different drugs or 5 different drugs at the same time and try to assess what is happening with the patient. They couldn't communicate well with medical staff. And so we went back and said, we have to dedicate a lot more time to therapeutics, to actually on-site clinical work. They have to get used to talking to doctors. Maybe we'll just start out by talking to medical students. So pharmacy students talking to medical students, going on rounds together and kind of growing up together. And that really worked very well. And we had to change the curriculum. We had 1 year that was just awful because we were doubling up. So we were doing clinical rotations at the same time we had classes. students would start class at 7 o'clock in the morning. We were working 24/7. It was a rough time, but we got over it. We made it. We got some more money. The federal government helped out a little bit. There was Senator Alan Cranston from California had a bill that helped schools of pharmacy implement essentially clinical programs, and that gave us some more money, which we sorely needed. When I first started at the school, we were considered clinical faculty, and the staff, the secretaries, and everybody else thought that was sort of second-class citizens, and we didn't each get our own little mailbox.
Wow.
We had to share one mailbox with a little manila folder in there for each of us, you know, that kind of stuff.
Wow.
So eventually, we outgrew the UCSF Medical Center. We had to place our students elsewhere. You couldn't just put 100 students up on one ward to see, you know, 200 patients.
Mm-hmm.
So we went and established programs at San Francisco General, Zuckerberg, now called the Zuckerberg Hospital, at the VA San Francisco, local communities, local pharmacies, actually, a retail pharmacy that did a lot of work with nursing homes, the Jewish Home for the Aged in San Francisco, who had a pharmacist, and that was a wonderful experience. And eventually, we had to move out of town. So the UC systems, like these multi-university systems, had 9 campuses, 5 medical schools, 1 pharmacy school.
Oh, wow.
Yeah. So UC San Diego, when they hired a new dean, Jack Moxley, wanted to make his medical education much more interdisciplinary. So he contracted with a nursing college and talked to our dean, Jerry Goyen, and said, let's do something in San Diego. Can you come down here? And we spent, this is in the early 70s, I don't know how many times I flew down to San Diego to talk to different people. I had to have buy-in from people like the chief pharmacist at the hospital, who was initially sort of reluctant to see us coming in there and telling him what to do. So we made him an assistant dean, and that took care of that. We also co-funded, he had 1 resident, I said, well, let's make it 2. You know, we'll pay for 1 and you pay for 1, and we'll kind of add to this program a little bit. So that worked very well. To make that long story short, that became the School of Pharmacy at UC San Diego, where Dave Adler is now. Dave was our guy that we sent down to San Diego, and he was willing to move his family down there and start all over again in San Diego. Wow. And we sent up to 20 students every year down there. And we replicated that at UC Irvine. Sam Shimamura was the guy that headed that up. Barbara Sauer did one at UC Davis. Mm-hmm. And we were also down in the Central Valley in Fresno, where there was also UCSF medical students. And the whole thing just kind of grew very, very, very nicely. Mm-hmm. And in the meantime, we had to do a lot of things. Like you mentioned, there was no textbook in clinical pharmacy. So Marianne Coda-Kimball wrote one. Joe Hirschman and I wrote one. We did a column in the APHA Journal on current therapeutic concepts. We just wanted to introduce the idea of therapeutics, of drug therapy and drug therapy management. And of course, we had a lot of visitors and a lot of invitations to come and visit other places to tell them what we did. You know, I went to Australia, I went to Chile. I spent a fair amount of time down there trying to talk to them, because that was kind of a mess. They were having strikes all the time, and they were trying to get rid of their president, Allende, when I was there, and they were actually shooting in the streets by the time I left. So that was not one of the great experiences, but it was a learning experience for me. Uh-huh. So I was very fortunate. so that's half of my career, and that ended in '93, I think. Jerry Goyen had left, so he was my mentor. And I had a visit by an entrepreneur from Silicon Valley who Jerry introduced me to. Went to see Jerry first because Jerry had then been the commissioner of the FDA, so he knew all about how to get drugs approved. And he said, I think we have a drug. And can you help me maybe recruit somebody? And Jerry called me on the phone. I took the elevator up to the ninth floor where his office was. And we sat down and talked, and eventually this guy offered me a job, which I did sort of on a consulting basis for a while, but eventually a couple of things happened that made it a good time for me to move on and do the same thing I'd done before, but in an entirely different environment. And one was what they call VERP, voluntary early retirement.
Oh, right.
California was going through an economic crisis.
Right.
So let's get rid of these high-paid senior faculty and hire some young people. And we'll give the senior faculty a bump on their years of service, and everybody's happy. So that worked out fairly well. And I went on with my career where I actually took a lot of the concepts that we had in at the university at UCSF, where we were basically influenced physician prescribing, but very focused on oncology. So this was all trying to organize doctors' thinking in terms of drug therapy and how to do it, and how to do it predictably and repetitively in a way that we could collect data. Because up until then, they would admit it, every patient was an experiment with an N of 1. So somebody would come in with the same diagnosis the next day and they would do something slightly different. So you could never aggregate the data in any way to look at it and say, this is working and this isn't working, because they never did the same thing twice. So we developed treatment protocols, algorithms, and I hired some of my residents and students, and for a while, people like Marianne Cotter-Kimball, who took over as chair of the department, was not happy with me. She said I was stealing her faculty and her best people, and there's some truth to that. I just offered opportunities. So anyway, I went on and did that, and eventually, I've retired 3 times. So the 3rd time, I sat around. I'm talking to you from Petaluma, California. You ever heard of it?
No.
Okay. It's the gateway to the wine country. It's about 40 miles north of San Francisco.
Oh, okay.
Yeah, so it's very pleasant, very nice up here. But so I retired up here and was bored to tears and sat down and wrote a business plan, and that's how we started NOAA, National Oncology Alliance.
Wow.
Yeah. So then I brought in Mike Cunningham and Kevin Redondi, a couple of my ex-residents from UCSF, and we started a company that was very successful, and we eventually sold that to McKesson.
Oh,
and they were headquartered in San Francisco at the time, so that was very convenient for us.
Yeah. Wow.
So I've been retired ever since.
Wow.
That was in 2006.
Wow. Well, that's I really appreciate those insights into your journey. Wow, it's amazing. This will be great. So the next question has to do with your legacy in 20 years. What do you think, and I rephrase legacy by saying, what are you most proud of, briefly, in terms of your contributions to help advance the profession? If you had to pinpoint things you're most proud of, what would that be?
If you Google me, you'll find out that the university just established a chair, the Toby Herfindal Presidential Chair. And I'm kind of proud of that because it took that whole history that I gave you and kind of summarized it, but with a focus on entrepreneurship. And so the money in this fund, and the university came up with a matching fund of $500,000. So it's a presidential chair. And so that'll give students and faculty access to resources if they are focused on doing something that's considered entrepreneurial.
Oh, wow.
They're
Wow.
risk takers. They're willing to do
Right.
something that might 10 years from now have an impact on healthcare or on the curriculum, on pharmacy, whatever the topic might be. So I think that's probably high on my list.
That's great. That's super. Very good for that. Thank you for that for the students. What advice do you have for students in their professional journey as they become leaders? And when we talk leaders, I'm talking about often it's little L, people who help have a vision and help advance the profession as leadership. Advice you have for our students?
Advice? Okay, I go back to what I said initially. We started this clinical pharmacy thing at UCSF, and I don't think we necessarily invented it. University of Kentucky and a number of other places did very similar kinds of things. I think we did it more completely and aggressively, and maybe with more support than anybody else. So it took root very early. But I think what you had was a perfect storm. Mm. You had frustration with the profession. When we first started, the American Pharmaceutical Association Code of Ethics, way back in '66, said pharmacists do not discuss drug therapy with patients.
Right.
That was considered unethical.
Right.
Right, and we did it all the time, and it took another 4 years later, they changed all that, but that was totally contrary to our belief. And we said, what are we doing in a profession where the ethics says you're not supposed to do what you're doing every day? And if you looked at the California pharmacy law, none of what we did was covered in there. I mean, if you relied on the law to understand what the profession was, I didn't recognize any of it.
Right.
They were just concerned that the shelves didn't have any dust on it, you know, that kind of stuff. So you had this frustration. We were overeducated, and this maybe lead to the whole coronavirus thing and what's going on in society today. Society was in a turmoil. The Vietnam War had just started. Have you been to University of California at the medical center? You should take a visit, but you can actually look down the street to the Haight-Ashbury.
Oh, wow.
So we were right in the middle of it. I mean, I can remember doing a peace march with our faculty, with our senior faculty, when Nixon decided to bomb Cambodia. We marched downtown, and it was just like what you see on TV today, except we didn't wear any masks. But you had this perfect storm. Society was in a turmoil. The profession was not going anywhere. We were frustrated, and we were willing to take a chance. And I think what I would tell students is you got to take some chances. And pharmacists classically have been order takers. I mean, we were always taught to interpret the prescription absolutely technically correct. Everything is got, the math is going to line up, everything is going to line up. So that's not the material for leadership. So if you want to be a leader, you've got to set an example. You've got to be a risk taker. You've got to have a vision. That vision doesn't have to be absolutely perfectly worked out. It'll change over time, but you got to have a drive. You got to have something in your gut that says, I have enough confidence in myself that I think I can do something here. So.
Wonderful. That's great. I love it. Echo. Good. So yeah, tied into the COVID. So the last question, as this is being embedded in a history and pharmacy leadership course, as we study the decade of the 2020s, one of the key events in that decade will be the COVID-19 pandemic, like other events in our history. You talk about a perfect storm. How do you see the COVID-19 pandemic being recorded as a turning point in our profession, and especially an opportunity for the profession?
I think it is an opportunity, but it could go either way.
Mm-hmm.
I mean, we could be relegated to just the order takers. But what it's done is it's really highlighted the inefficiencies in the American healthcare system
Mm-hmm.
as it relates to prevention, treatment, interception of or detection of disease, and the whole issue of access to care.
Mm-hmm.
I mean, why is it that Latinos have a higher incidence of COVID-19 than whites?
Mm-hmm.
Why is that? A lot of issues. Most of it has to do with tight living conditions, but what's that got to do with it? That has to do with economics. I was listening to testimony the other day, and one of the big five, it wasn't Fauci, it was somebody else, said they were talking about the things that were going on in how we were dealing with, how we were identifying patients. And he mentioned pharmacy, which I thought, wow.
Right.
Federal law now says pharmacists can get involved in testing, and it's an emergency measure. We need to make that permanent.
Right.
We need to have our leaders of our organization back there trying to make that permanent. So I think we can have a meaningful role going forward. It's not the last epidemic we're going to have. Now, viruses are a lot more, they're smarter than we are. And there would be more of those kinds of things. But think about pharmacy. They're in every community, in underserved community, in every community, there is a pharmacy, there is a drugstore, there is a pharmacist. He's an underutilized individual that if we grab a hold of this, and I think what we need to do is what we did with the 9th floor and what they did in Kentucky and other places, is you got to demonstrate you can do something. Nobody's going to give it to you. You got to take it. And that's the opportunity we have with this coronavirus. And I think it's the first one. I mean, the last big one was over 100 years ago, but I don't think it's going to be another 100 before we have another one. And so being involved in prevention, detection, and treatment is an opportunity for pharmacists. And eventually we're going to have therapeutics. We're going to have drugs that deals with it. And that's our domain, right? And we're going to have vaccines. And we are now considered one of the primary sources of vaccines for vaccines and other things.
Yeah.
So we're perfectly set up. We just got to take advantage of it.
Very good. Wow. You know, it's a pleasure. I'm glad I had this opportunity to share these moments with you. Thank you very much.
Thank you.
For now. Thank you.